Welcome to the Regional Geriatric Program of Eastern Ontario's Regional Geriatric Rounds, the last one of the year. My name is Heather McLeod, and I'm the Knowledge Translation Specialist in Geriatrics for the RGPO, and I'll be moderating today's session. But before we begin, we would like to take a moment to share a territorial land acknowledgement for Ottawa, where we are hosting today's session. The RGPO offices hosted at the Ottawa Hospital and are located on the traditional unceded territory of the Algonquin Anishinaabe Nation. The Algonquin people have lived here since time immemorial, and we are grateful to have the opportunity to present in this territory. Today, Pam Howell will be presenting on tackling medication challenges in older adults, practical tips for everyday practice, and followed by time for questions. At any time, you may type a question into the chat box, or after the presentation, you can use the raise the hand button, and we will invite you to unmute your mic to ask your question. Pam is a pharmacist working for 20 years with older adult clients and clients with complex chronic conditions at Brier Continuing Care in Ottawa. From 2018 to 2020, her role with Brier Deprescribing Guidelines team focused on knowledge mobilization, community engagement, and research efforts to highlight the importance of deprescribing as part of good prescribing. More recently, her passion to help her patients has led her to join GeriMedRisk, an interdisciplinary virtual consult service supporting clinicians caring for older adults with complex physical, mental health, and medication needs. She also serves as the GeriMedRisk liaison, collaborating with clinicians in geriatric services within the Champlain region. Welcome, Pam, and thank you for joining on this morning.
Thank you very much, Heather, for that great introduction. And I had to see my picture there and I'm like, oh, that's me. So I want to thank everybody for taking their time this morning, and to be mindful of that, we'll get ourselves started. So we are going to be tackling medication challenges, and I'm hoping to give everyone those practical ideas to hopefully help with their patients from day to day, knowing that there's a lot of challenges out there. So hopefully I'll be able to partake a little bit of what I've learned through all of this. So as far as disclosures, I don't have any for-profit or commercial conflicts of interest, but as mentioned, I do have affiliations with GeriMedRisk, as well as Brier Continuing Care, and I really want to acknowledge the passion that I have from the support and guidance from the Brier Deprescribing Guidelines research team with some of the content and with a lot of what I've learned. As far as the objectives today, I really do want to review and reflect on key factors in older adults that make medication prescribing a challenge. I do want to offer a case-based pragmatic framework to help guide medication decisions and discussions. And though I really wish I had 3 days to do this, I hope to try to cover some key points of what I've learned in the last 20 years of my practice. As well, lastly, throughout the presentation, I want to highlight tools and resources available that support clinicians and patients with medication changes. Though it won't be an exhaustive list, it'll hopefully provide a kickstart for everyone to start exploring what really is out there. And lastly, I really do want everyone to kind of keep their minds open and hopefully think like a pharmacist. So really the major few things that are coming up with older adults is that we're finding with medications, there are a lot of pharmacodynamic and pharmacokinetic changes that we need to be aware of. Really, there are things that change within the brain as far as increased permeability for medications. There's a lot less muscle mass or more body fat. There's reduced liver and kidney function that can lead to reduced ability to metabolize or excrete medications. And sometimes dehydration can really lead to higher serum levels in the body. Ultimately, what that means for older adults is that all of these factors into play increase the risk for experiencing side effects. And so what does that really mean, and what's the prevalence and impact of that medication kind of complexity in older adults? And it really means that as they're prone to polypharmacy, they're trying to deal with taking multiple medications every day. And though polypharmacy is a worldwide problem, the Canadian Institute of Health Information reviewed that the Canadian landscape really reports significant statistics right here in our own backyard. As you can see here, 1 in 4 Canadian seniors are reported to take take 10 or more medications in 2016. And more alarming is really that approximately a 1 in 140 adults are hospitalized due to those harmful effects of their medications. And 58% of these were older adults, even using 10 or more of drugs. And ultimately, there's even a driving factor that goes further that says almost half of them, 43.7%, were prescribed a potentially inappropriate medication. And ultimately, there's even other adverse effects that we really want to think about with medications in older adults. And those things could be links to falls and cognitive impairment as well. So what is polypharmacy, now that I'm bringing up that word? And ultimately and historically, it's always been related to a number, whether it's been more than 5 drugs. And unfortunately, more recently, we're even looking at numbers like more than 10 drugs. It's been coined since the mid-19th century. But there's evolving definitions now, and you can see that people are now trying to really rationalize medication use as appropriate polypharmacy or problematic polypharmacy. So when it's appropriate, we're really optimizing medications. And the goal is to maintain that quality of life, improve that longevity. There's minimal harm to the patient, and they are able to adhere to it. So they're finding that it's not a motivating factor that they can't keep up with. But on the flip side, there's the problematic part of it, where we're actually prescribing multiple medications that could potentially be inappropriate. The potentially inappropriate medications are really the ones that have no clear evidence for their indication. They could carry a substantial higher risk for adverse effects, or they're really not cost effective. And in the end, that intended benefit that when it was prescribed is not realized. The other contributing factors to polypharmacy is that there's a growing body of evidence focusing on the impact of something called a prescribing cascade. And what that really is that Rochon in 1995 described it as occurring when a medication side effect is misinterpreted as a new medical condition and a subsequent potentially avoidable drug is prescribed to treat that side effect. So then you can see how that can lead to more and more medications being added to an older adult's medication list when you're not taking that step back and asking, is it really caused by a drug? The identification and stopping of a prescribing cascade is often overlooked by clinicians or underappreciated, and really translates into a missed opportunity to improve medication safety. Some examples I've listed here. You can see that things like codeine can cause constipation, which then means you need to add on a laxative. Or it could be something like amlodipine that has a side effect that causes pedal edema, which then leads to a clinician thinking about adding furosemide or Lasix as a water pill to get rid of that fluid, instead of really trying to reduce the amlodipine or stopping it. And so if we know so much about medication inappropriateness in older adults, and it's been studied for so long, why is it continuing? And that's really where I wanted to bring in this slide. And as busy as it is, I think it really reflects and impacts on how many factors there are in interplaying with why prescribers prescribe the way they do, or why medications maybe aren't optimized to the fullest. There's a lot of challenges and barriers sometimes that clinicians feel kind of frozen as far as what they can do and what they can't do. And so really in the next little while, I wanted to try to focus on a few that have come across my practice quite consistently, and hoping to kind of bring out some key points and how to overcome them. So really those prescriber beliefs as far as what are the negative consequences of change and they don't know about it. Sometimes that lack of evidence as far as, optimizing medications or deprescribing. It's really the time and effort sometimes that it requires. So medications changes sometimes do require a lot more monitoring and follow-up. And as well, those patient beliefs that they're just not sure about what's going on and why are we changing things, and trying to overcome that. And really this article that I had come across really struck a chord with me because it really relates to the slide previously, where supporting medication discontinuation, as far as a preference was concerned from primary care prescribers, this national web-based survey of US Veterans Affairs looked at the fact that many prescribers felt that if there was an indication for use or that knowledge of what it was originally prescribed for would ultimately help whether they're going to change it or optimize it. And additional priorities that they also found is that support from follow-up and assistance with follow-up from other healthcare providers and increased patient involvement in prescribing decisions would actually motivate them a bit more to feel supported and feel like they can make medication changes appropriately. So as far as trying to now look at how do we optimize medication, so if you are motivated and you really want to try to improve your patient's care, how do we do that? And as a pharmacist, really my foundation has always been within the pharmaceutical care process from Hepler and Strand, looking at trying to assess drug therapy and how does that look. And for us as a pharmacist, we really look at whether those signs and symptoms are related to a drug or a disease. So that's usually the first question I tend to ask myself. And for most clinicians, the easier path is to go down that disease route because that's the comfort level that we have. But for me, the first route that I go down is that drug route. And for the most part, reverting to that really does point to optimizing and being able to address drug side effects and adverse effects that patients might be experiencing. So for the rest of our time, I'm hoping to walk through a case and do a stepwise approach that might help how to identify drugs of concern and what we can hopefully do about it. So I want us to meet our patient, Mrs. PH, who is a 78-year-old female. She's new to your practice, and you're meeting her for the first time in the presence of her daughter. Based on her electronic health records, you see that she has a past medical history significant for hypertension only. She has no history of cardiovascular events or diabetes, and she unfortunately hasn't had any blood work done in the last 12 months. Upon further discussion, she tells you that she's recently been diagnosed with GERD, and after having much prompting by the daughter, she admits to a fall about 4 months ago that has resulted in significant back pain and a trip to Emerge. She's been going to walk-in clinics since the retirement of her primary care provider 6 months ago for any issues or refills. Socially, she's widowed. She lives at home alone, but she has a very supportive daughter that's with her today. She's still driving and she loves playing her Scrabble. Your observations during the visit is that you notice she's walking without a gait aid, but looks really unsteady and slow to move. She doesn't appear to be in any pain, but she reports that the pain is constant and usually 6 out of 10 worse with movement. You notice that she's got bilateral pedal edema. Her blood pressure is about 130/80 while she's sitting. And you're also noticing that she's having some word finding difficulties. She's slow to respond. The patient herself reports no concerns with cognition, but the daughter has noticed more memory issues since the fall. And as we can see, her medication list isn't horrendous. It's definitely not a long list when you think about the polypharmacy numbers that we often see in our older adults. And you notice that she's on blister packs. So she has no known drug allergies. And based on her blister pack, she's on amlodipine, lorazepam, pantoprazole, gabapentin, and furosemide. And in a separate vial, she has hydromorphone, where that is 2 milligrams every 4 hours if she needs it. And the last time she filled it was 2 weeks ago, and she's only got about 4 tablets left. You're finding that this interaction is quite challenging, as you're concerned about what you noticed in her medications and whether any of them are contributing to her symptoms that you've noticed when she's come in. But really, all she wants is that refills, and she wants to just get going on her day, and she's not exactly sure why you're even questioning what she's on. For those of you in attendance, I hope that one of your questions as you're reflecting on her medication list is there more to this story? Is this really all she's taking? Is this really all she's doing? Are these medications really working for her? And from my 20 years of experience, I can safely say that there usually is more to this story. And so now, where do we start? So step one is really preparing for a long-term process. I don't want to scare anybody, but I do say that there's 3 reasons for this. One, successful changes are sustainable, that are sustainable, do take time to assess, come up with a plan, and implement to completion. So you want to make sure that whatever you're going to do is really going to stick. More than one drug really sometimes may need to be changed, and often changes shouldn't happen simultaneously. So sometimes it's a one step, and then you move on to the next, and then you move on to the next. And lastly, I don't want anyone to feel like you should overwhelm yourself or the patient with thinking that everything needs to happen right away. My biggest thing with this is that Rome wasn't built in a day. So don't expect that medication changes are going to be happening right away as well. Step 2 is performing a best possible medication history and experience. So that really is that interview foundation process to find out exactly what the patient is taking. And so the key principles with this is about the medication specifics. Really, you need to use 2 or more sources. So that is the patient and caregiver needs to be one of them. And then those other sources could be things like your Ontario Digital Health Drug Repository, known as the DHDR for most. It could be the community pharmacy records. It could be consult notes. It could be discharge summaries. It could be a combination of everything. But really the reason why you need more sources is because all of them do have limitations. And so you do need to be aware of those things. For instance, with the DHDR records, they only actually reflect what the patient is taking that is covered by the Ontario Drug Benefit Formulary. So there could be medications on those lists like over the counter or things that are not covered that the patient could actually be taking. So you don't want to just use that one list as your source. Always include the exact dose and frequency, and that is what is reflected with what the patient is actually taking, because there's many times where there's discrepancies where the patient is taking it one way, but the pharmacy records may say a different way. Definitely include all over-the-counter, herbal, cannabis, alcohol, homeopathic, all of those things, even though they may not seem significant to the person in your care, they actually are, because they will have side effects related to them, and there should be caution taken with them as well. Use prompting questions. And I think that's because a lot of the times people don't associate maybe some of those over-the-counter or herbal products as medications. And so they may not actually report them to you, even though you say, okay, well, what medications are you taking? And as well, those administration details, things like timing. Are they taking it in the morning or at night? Are they having swallowing issues or crushing of medications? And the reason why that's important is because if there's things like long-acting medications, it could actually alter the way that the medication works and actually increase the risk for side effects as well. So as far as the medication experience, so this is a little bit of a different kind of twist that I like to add into my medication interviews and histories, because of the fact that it gives a wealth of information as far as those perceptions that the patient might have, as far as their indication that they think that the medication was started for, what their perceived effectiveness of that medication seems to be. Is it working? Is it not? They can tell you things like timing of the initiation. So when did it start? Who recommended it? Have there been any recent changes lately? Any previous drug trials that they might have tried that didn't work, and prompt about regarding those specific side effects and the timing of them. So unless you ask about certain side effects, they may not actually associate them with medications. And as a little example here from the National Health Institute of NHS, they actually produced a document that listed or kind of linked anticholinergic side effects to medications themselves. So it's a good cue or visual example of how you can kind of link those two things together. And also assessing for intentional or non-intentional adherence. So that kind of an idea is where that patients may sometimes not mean to miss medications. So, they may forget, they may have been distracted, but there's also that intentional part where they actually don't want to take that medication, or they've stopped taking it, or they only take it when they feel a certain way. So thinking that just because you put a medication in a blister pack or that you've prescribed it the way you have may not necessarily come out that way in what's happening at that person's home. So being aware of those kinds of limitations is quite important when you're doing a medication history. And I know that that this process sounds quite laborious, and it is. But I think that there's ways to support overcoming some of the time that is required in this kind of a process. So I try to think about it as, booking that appointment or having that dedicated time. So that way you're not rushed with other competing priorities. Think about giving patients homework to do this. So maybe it's not at this appointment today, but you're going to revisit it in a couple of weeks and have them come back in. So in the meantime, have them try to go through that process of what medications are you taking, go through every single one of them, and write it down for me. And as an example, the Briere Deprescribing Guidelines team has come up with a really nice fillable medication record that's a possibility. There's many other apps out there as well. One is available through the Institute of Safe Medication Practices. And so finding those kinds of little keys to help the patients themselves figure out what's going on is useful. Explore options that could help with your efficiency. So as I had mentioned, the Institute of Self-Medication Practices in Canada actually offers educational resources on how to do a best possible medication history. So if it's not yourself doing it, maybe there's someone in your clinic that you could help train and help you do that with the patient and walk them through it. Your pharmacist with the Meds Check program is quite a good resource, and I'm always going to push them. There's multitude of other people. Could it be one of your clinic nurses? Could it be a caregiver or a family member that could help, document all of that information? And then are there community care or geriatric specialist services maybe that could help you through that process as well? And more detail to come with that. So with Mrs. PH, you're trying to say, okay, well, what is her medication history and her story? And so I'm going to try to walk you through a little bit of what she told us. So, appreciating that medications she's taking and why and the available history is really a stepwise process to see the progression of her symptoms. And you can see that for many years, she tells you that she's been on amlodipine daily, but about 6 months ago, she had an unfortunate loss of her husband and was very anxious and couldn't sleep at that point. So her family doctor decided to give her lorazepam 2 milligrams at bedtime. About 4 months ago, she had a fall and really experienced a lot of back pain. And so on her own, she decided to self-prescribe ibuprofen and glucosamine. And these were really highly recommended from a close friend. 3 weeks later, her back pain still wasn't getting any better, unfortunately. So the Emerge physician decided to give her gabapentin and gave her a short course of hydromorphone PRN. About 3 months ago, the pain was still continuing. And so she's, bumping up her doses, and now she's taking hydromorphone very regularly 4 times a day. And ibuprofen is now 4 times a day. And because she needed refills, she went to a walk-in clinic. And at that point, they gave her the refills for the hydromorphone, but also noticed that her blood pressure was up and so increased her amlodipine. About 2 months ago, she's noticing that her stomach was really bothering her. She was getting more nauseated and just couldn't handle it anymore. So went back to the emergency room. And at that point, they gave her pantoprazole to help with the GERD because that's what they thought it was. And as well, they noticed that her legs were swelling up quite a bit. So they decided to give her a prescription for furosemide daily. And because she's really not interested in being nauseated every single day, and that really makes her anxious, she's been deciding to self-prescribe dimenhydrinate or Gravol before breakfast as a preemptive kind of thing. And as you're kind of going through her medication list, you see this big red flag. And from your learnings, you know that lorazepam is not always an appropriate medication in older adults. And you're really thinking to yourself going, oh my gosh, we need to get rid of this medication. And as you're asking her about it, you finally realize that even though it's in her blister packs, she's telling you that 2 months ago, she actually stopped taking it because it made her kind of feel groggy and dizzy during the day. So even though it's still in her blister pack, she takes it out and she actually doesn't ingest it. And so you can see that this foundation is somewhat crucial for a successful outcome because of the fact that you're realizing that she's taking certain things that are not in blister packs. She's taking things on her own. Even if they are in the blister packs, she's actually not taking them. And so the assumptions on a kind of a face value without asking these particular questions can be very detrimental with trying to prescribe or make optimization changes later on if you really don't know what the story is from the beginning. So for Mrs. PH, her key points, when you look at her complete medication list now, we know that she's on the amlodipine 10 milligrams, that she's taking ibuprofen 4 times a day. She's taking hydromorphone 4 times a day. She has her gabapentin. She has her furosemide or her Lasix. She has her pantoprazole in the morning. And that she's taking preemptively dimenhydrinate before breakfast, and that she has her glucosamine as well to help with pain. And so some of the key points that I really want to bring out with this is that first and foremost, I think we all need to think about reconciling discrepancies. And the reason why I say that is because if that doesn't happen, there's those unintentional adverse events that could happen. So what if Mrs. PH was actually admitted into the hospital, and as far as they're concerned, the blister pack says that she's on lorazepam 2 milligrams QHS. They would actually prescribe that and unfortunately would probably administer it to this patient, even though she's technically not taking it. So there's always those risks with that. So reconciling those discrepancies within the community pharmacy records, within your records, within any specialist records are really important to keep those consistent. Timing of medications can help identify those prescribing cascades that we talked about. So being able to see when timing was, when did a symptom happen and did a medication kind of start thereafter that could have been avoided. And in this case, you could see, hopefully, maybe there were a few things that you noticed in her list. In particular, the amlodipine increasing from 5 to 10 milligrams caused that pedal edema that then led to the prescribing of the furosemide. And as well, I think we learned a lot of insights from the patient that she shared. When you asked her a bit more about her pain, she said that good pain control is really important to her. She really finds that the hydromorphone is working, but she's not sure about the other ones. She finds that her GI symptoms are better with the pantoprazole and the Gravol potentially, but that she really hates being nauseated, and that she really does trust that medication information that she got from her friend. So, that glucosamine ibuprofen came from a really good friend. So trying to adjust those medications may require a bit more finesse. And she also endorses that she's constipated and that she's often dizzy when she stands. Before we can actually move on into making medication changes, I think there's an important part, and this is the step 3. So it's exploring that patient's perspective, and I'm going to try to address it in the next few slides. And I think it's really having that supportive and mindful approach about medication changes. Discussions about changes can really be influenced by the patient's readiness and awareness. And a lot of my work with the deprescribing team and with GeriMedRisk has really identified that patients often aren't aware of their role in the circle of care and in their medication decisions because they've never, experienced that kind of discussion with their primary care providers. And sometimes their interest to actively participate is there, but they won't be the ones to actually initiate it because they're worried about the ramifications of that. So it's kind of like that dance, in grade 8, where everybody really wants to ask to dance and wants to dance, but the boys are on one side and the girls are on the other, not exactly sure how to initiate that first conversation. So sometimes it's breaking the ice that really, is our role as clinicians. As well, the patient's medication knowledge and health literacy, you don't know what you don't know. So trying to educate patients on knowing about what kind of questions to ask and about their medications and what they should know about their medications is important. Experiences with conflicting messaging really is about the fact that you go to a doctor and you're expecting a prescription, not the discussion about the fact that you're going to be changing or stopping certain things. So that sometimes takes patients aback. And as well, their relationships with their healthcare providers. In Mrs. PH's case, you're someone new to her. She doesn't know you from anyone, but yet she had a very long-standing and trusting relationship with her primary care provider that had just retired. So he had prescribed all of these medications, and now you're telling her that they're not potentially the most appropriate. So those kinds of things really can pose some detriment or challenges when you're talking about medications. On the side here, what I did want to actually, identify are a couple of resources to kind of help these conversations. And one is from the deprescribing.org website, talking about medications and they're important in their role. And then the Institute of Self-Medication Practices also provides five questions about your medications. That's very good to kind of highlight what kind of things patients should know about their drugs. And conversation starters. One may ask, well, how do I start this conversation? Because it potentially could be very awkward depending on the patient and your experiences with them and your relationship with them. And I find this article from Farrell and al. Is a really good starter. And I love this figure. It really does introduce things like conversation starters, how best to say something, how best to phrase it in a way that doesn't come off as, saying that you know what's best and that you're going to make changes whether they like it or not. And I think the second piece of advice as far as these conversations are, yes, they're awkward, but I think the more practice and the more that you do them, the more that you engage in them, the better you're going to become. And so keep practicing and keep doing it, even if some become challenging, because they do get easier. Other key points sometimes with overcoming hesitancy that I like to think about in my practice is trying to focus on what is important to the person in front of you. So could you kind of phrase things as far as functional improvements? So for Mrs. PH, maybe it's the fact that she really wants to keep driving, and because you're worried about her cognition, you want to kind of connect that. Well, if your cognition isn't very good, then driving might be an issue, and maybe it's your medications. Be creative with presenting benefits and harms with medications. So are there pictorial representations of things like numbers needed to treat or numbers needed to harm that could give patients a visual of exactly where do they fall in those numbers? Give that dedicated time and space to process the information. So sometimes people need to maybe go home and think about it. You can provide them with educational resources to read up on the concerns that you're having, and then give them time to come up with questions and ideas of what they want to talk with you about at the next appointment. Enlisting the help of caregivers and families as well to support maybe some of those conversations or support monitoring, and think about other health care providers that are involved in their care that could help with things. So maybe they have a very good relationship with their community pharmacist that could help support the monitoring and medication changes, and as well ensuring consistent messaging by colleagues. So if there are physicians in your office that might be covering for you while you're gone, or even thinking about the fact that when the person is actually calling to make an appointment with the receptionist about a medication review, she actually knows that that's something that you tend to do quite often because of medication issues. And as far as patient-focused education materials, I did want to point out these ones that I really like from the Canadian Deprescribing Network that talk about things about, how to get a good night's sleep without medications, education about medications that could be potentially inappropriate, or even about deprescribing in itself, because that's really a new concept for a lot of patients as well. And so these kinds of educational materials that there are a plethora out there could be something that you could give someone to take home, read, think about, and then come back to you. So step 4 is now identifying those opportunities to optimize the medication regimen. And so this is, really getting into the nitty-gritty. And key principles here are really trying to link symptoms to those potential drug side effects in an effort to avoid prescribing cascades. So instead of moving forward and saying, oh, we need to prescribe another medication, step back and say, okay, can this side effect actually be from a drug? Identify an indication where possible. So knowing what kind of things this medication was supposed to do may hopefully help with the monitoring to make sure that it's not getting worse when you may be changing it. Assess the appropriateness of the dose and the frequency. And I really want to highlight that this is for an older adult. A lot of the times you'll see that starting in target doses for older adults are often lower than what you would see in a normal younger adult. And much of the time, those doses are also impacted by the patient's renal function and liver function. Identify any potentially inappropriate medications. So there's many tools that I'll go through in the next few slides that help you do that. And also review drug interactions. So those could be pharmacokinetic, so what happens in the drug and how it's processed, or pharmacodynamic, so how drugs in the body may actually interact together. And this helps you identify if a drug level in the person's body, and doing this initially may help with knowing, well, maybe the drug level is a little higher in this patient than you might want to expect, which then may lead to higher side effect risks as well. And as well, sometimes the symptoms that you are noticing in this person could actually be more pronounced because of multiple drugs. So sometimes there's that little play and dance with medications within the body where they're actually having additive effects and could be making the symptoms worse. So a lot of the tools that may help you assess risk benefit and potentially inappropriate medications can be things like drug specific. So things like your Beers criteria, stop frail, your class specific. So those are guidelines that help you look at classes of medications and how to deal with them. In particular, the deprescribing guidelines. The Primary Health Tasmania has some really good repertoires, and Choosing Wisely Canada is a really nice one to go to as well with their toolkits. And then there's a lot of electronic decision support tools online that are freely available that help walk you through some of the decisions with certain medications. So MedStopper, for instance, you can type in all of the medications that a patient is on, and at that point they can kind of highlight priorities for potentially inappropriate medications and potentially what you could do with them. Other resource options that I like using as well, unfortunately some of them do require a subscription. So RX Files is a really nice one that has geriatric focused information. The CPS has information that is specific to sometimes therapy problems or medical conditions or drug or signs and symptoms, up to date, and as well your pharmacist. I can't say enough about the profession as far as trying to help manage and identify those options for you. Next slide, please, Stephanie. Thank you. And as well, drug information resources. So as I had mentioned, sometimes medication doses or side effects or interactions are more pronounced in older adults. And so GeriMedRisk has actually identified a gap in that kind of information and has started compiling many drug summaries or drug information resources that are freely accessible on the website. So I do encourage you to maybe check those out if there's any of interest, and they can help get those to you. So for Mrs. PH, pulling all of this information together, what you can notice is that from her medication list here on the left-hand side, if I did the review of potentially inappropriate medications based on Beers criteria, stop, start, and all of those references, you'll notice that every single one of them actually is a potentially inappropriate medication. So now the question is okay, well, now what do I do with this? And so the next step that I usually think about is, okay, well, what are the potential concerns and are they linked to any medications that the patient might be on? So we identified that we think she's, at risk of falling. She has had a fall. And when I do a review, for me, I noticed that hydromorphone, gabapentin, amlodipine, furosemide, for a multitude of different reasons, whether it's for blood pressure lowering or causing peripheral vasodilation, can contribute to falls. Are the medications that could contribute to her cognitive changes. So reviewing side effects links things like hydromorphone or gabapentin. Are there other drug side effects that could be in play? So the patient had mentioned GI upset, which that, could that be related to her ibuprofen or one of her other medications? She mentioned fluid retention. Is there hypertension or hypotension going into play? Is she at risk for bleeding? So obviously with some of her medications like the ibuprofen and NSAIDs, we know that are related to a higher bleed risk. And as well, is there drug side effects like electrolyte disturbances with her medications? So things like the furosemide, where you might want to be wary of that and maybe investigate that further. And then the next step that I would usually look at is, are doses appropriate for her? So is she on too high doses? Should we reduce them? And being aware of the fact that medications like ibuprofen or furosemide can actually cause kidney injury or lead to kidney injury, which then means that many of her medications could be at higher levels in her body. And then looking at drug interactions again. So this is another opportunity to review what's happening with all of these medications altogether. And with this patient in particular, there's a lot of pharmacodynamic ones. So medications that have similar side effects that are, competing and causing more and more concern. And you can see that that above, the medications are more than one that could be causing cognitive changes or could be contributing to false risks. So step 5 is the planning. How do we do this? So we've identified that there's many medications that we could potentially be changing, but ultimately we want to come up with a stepwise approach or a stepwise plan. So a lot of the times it's trying to figure out how do you prioritize those changes. And when I think about things, I look at the fact that is there medications that are posing an imminent risk versus a potential risk. So the imminent ones might be ones that you might want to prioritize higher because of the fact that you're really worried something is going to happen. Versus the potential ones where maybe you could fit them in a little later or identify them later, depending on the patient's preferences. Are there further investigations needed? So as I had mentioned, things like furosemide or ibuprofen for Mrs. PH that could be affecting her kidney function, well, then maybe we might want to do some blood work in her, especially since nothing has happened in the last little while, and those medications have been added just recently. Prioritizing based on the patient preferences. So you may have an idea and you may want to really focus on a couple of medications because you've identified them as being potentially inappropriate. But if the patient is very hesitant and really not sure about it, there's really that, you're kind of going against the grain, and maybe that might not be the one that you want to go with first because you want to build a bit of confidence. And are there changes maybe that could help with even just adherence? So little changes like changing from a twice-a-day medication to a once-a-day formulation. Are there opportunities maybe to come up with combination products so that way the pill burden isn't so hard for the patient? And sometimes going with lowest hanging fruit. So once again, trying to build successes and confidences in the process if the patient is hesitant. So if they're really not attached to a certain medication and you think that that might be appropriate to kind of optimize or change, then maybe that's the one you go with first. The other kind of implementation considerations that I think about is maybe it's not necessarily that you want to not treat that condition, but maybe there's safer alternatives. So it could be for, say, something like diabetes, where you're looking at the fact that the patient is on glyburide, which really can cause hypoglycemia. So maybe we can switch them to metformin that might have a little bit of a less risk. You're also thinking about, is there tapering necessary? So some medications you can stop right away abruptly and don't have to worry about it, whereas others you do actually need to slowly titrate the dose down to make sure that you're not going to cause any adverse drug withdrawal events. As well, sometimes when you are doing a switch to safer alternatives, you might have to do a cross taper where you're lowering one at the same time as you're increasing another. Non-pharmacal interventions are really nice to kind of help support those symptoms in a way where they have less side effects. They still are just as effective and will hopefully increase the success of maybe stopping or lowering doses because of the fact that the patients feel better with these non-pharmacological interventions and don't feel like they need medications as much. Once again, drug interactions. And this is now a trickle effect that I want everybody to think about, because obviously if you're making medication changes, you want to make sure that it's not going to cause other drugs that the patients will stay on to have a disruption in their balance. So making yourself aware of those things and being able to mitigate those risks will be helpful. As well, thinking about, can changes happen simultaneously? Some can. So, you may be able to adjust their blood pressure medication at the same time as, stopping a B12 supplement because of the fact that their levels are normal. Whereas others where you might want to think about doing it one at a time. In particular, if you're trying to adjust medications that are treating the same kind of symptoms. So for pain in particular, you don't want to really stop or change two medications at the same time, because you may not necessarily know which one may have caused a problem if the patient experiences more pain. Can specialists help guide the process? So at that point, if you're not comfortable with exactly knowing how to do it, would you want to consult their cardiologist, or, if there is a rheumatologist involved, and you're thinking about making some medication changes, how can they help support those decisions and guide the process? And also looking at how can you mitigate risks for drugs that you can't change. So let's say a patient is really attached to a certain medication that you can't really deprescribe or make change to right now. Are there things as far as strengthening exercises or other modalities that you can use to hopefully help make sure that they might not be falling with that medication that you're concerned about? And last but not least, document and communicate your plan. And I can't emphasize that enough. And it's not just in your electronic health records, also making sure that you're communicating a plan through the prescription that you're writing to the pharmacy. Also as well, maybe sending a little small note about the changes that you're going to make to any specialists that are involved. So then that way, hopefully they're also aware of the plan of attack and that there's consistent messaging with that and that they're also on board with it. And documenting and communicating that plan with the person, writing it down, making sure that they know exactly what the steps are. And part of that process, as I keep mentioning deprescribing, and my apologies for not bringing this up sooner, but hopefully everyone out there knows a little bit about the terminology. But just in case, I did want to mention that really deprescribing is part of that process, sometimes with older adults and optimizing medications. And it's the planned and supervised process of not just eliminating medications, but also dose reducing to a more appropriate level. And so you're really looking at medications that are not, not maybe providing any benefit at any point and maybe causing more harm at this stage of the game. And really, it's all a part of that good prescribing process and that medication optimization that you're looking to do. And when people say, okay, well, how do I deprescribe? And when we talked about the fact that many clinicians may not feel comfortable with knowing how to do that, I would encourage you to start looking at those resources that are out there in the world. There's so many of them and so many great ones. And obviously, I'm going to highlight the deprescribing guidelines and algorithms from Briere. And I think they're really great as far as the development because they are evidence-based. They do provide a stepwise process. And right now, you have a free access on their website to a deprescribing guideline for proton pump inhibitors, anti-hyperglycemics, antipsychotics, cholinesterase inhibitors, and benzodiazepine receptor agonists. And hopefully on the horizon, we're going to see a new one coming out for statins in older adults as well. And as I had mentioned, their algorithms are really great as far as a quick and a visual cue about how to do that stepwise process and what kind of questions to walk yourself through, and providing options about how to deprescribe and then how to support those things with non-pharmacological options, and how to do the monitoring. Choosing Wisely also has some great toolkits as well, things like the Bye-Bye PPI. There's also one for antipsychotics in long-term care, and benzodiazepines. So encourage you to take a look there. And so now with Mrs. PH, we come back to her and say, okay, well, now what do? We have all the tools, we've done our assessment, and what can we do for this patient? Because we are concerned with certain side effects and medication overburden. And really the first sometimes go-to medication, because it's such a highly identified inappropriate one, is the hydromorphone. But if we did actually take a listen with what she was telling us, she really thinks she needs her hydromorphone at this point. She thinks it's the only thing that's working for her. So what do we do with that? And so if that's the case, I think that there's still more we can do for her. So moving on and negotiating sometimes with the ibuprofen, could that be something else that we could do? And committing to different processes and ordering investigations. Last is step 6 is monitoring and follow up. So making sure that you're providing that process. So key principles here are be clear and use specific parameters, subjective and objective. Include monitoring for things like adverse drug withdrawal events, so things that could come up because of the fact that you might be tapering too quickly, or a reemergence of underlying conditions that maybe we were trying to treat or weren't sure whether they were treating. So, there could be things like rebound pain if you're trying to get rid of a narcotic medication. Don't forget the positive improvements. Schedule touch points in person or virtual, and have a backup plan. If things aren't going well. So what does that person do if something's happening and you're not available? And involving the patient and caregiver to help with that. And as well, once again, document your plan in your electronic health records and with the patient. So supporting through community partners as well. So embracing that interdisciplinary approach. I can't tell you how much working with the Briere interdisciplinary team really brought that to light with me. So there's a multitude of different services out there that you could really lean on to help with in-home monitoring and trying to give you feedback on some of those medication changes. So liaising with people like your community pharmacist or your care coordinators or your PT, OT that might be going into the home. Sometimes I've looked at community paramedicine services that are really coming out. There are home monitoring services like Behavioral Supports of Ontario or the COPD CHF management through home and community care services. And even things like the community diabetes education program that can help with tapering and titration of things like blood sugar monitoring and glucose control. And last but not least, step 7 is revisit and repeat. So you've tackled one medication, don't stop there. Keep going, keep optimizing. Health goals and a patient's medical condition keeps changing. So medications need to change appropriately for that as well. And if you're feeling like there's too much complexity or you're just not sure about what to do with this person in front of you and you want some guidance, then I think really those in-person services are things you should get yourself more comfortable with knowing how to refer to. And thankfully, we have a great plethora in the Eastern Ontario region, thanks to the Regional Geriatric Program. So connecting with specialized geriatric services like the Geriatric Assessment Outreach Team, all of our day hospitals, our falls clinics, and geriatric psychiatry are just a few of the ones that we have available to us in our toolbox. And last but not least, but I also do want to, say that there are times where if you're finding that you just need a little bit of support, or maybe an in-person service may not be feasible depending on the patient dynamics or where you are. There are obviously a lot of virtual services now, thanks to COVID, where things are expanding and we're exploring different e-consult services. One of them that I did want to mention is obviously GeriMedRisk, that is near and dear to my heart. And it is a bit of a different one just because we are a clinician facing service and connects clinicians to an interdisciplinary team of geriatric specialists, so clinical pharmacologists, geriatricians, psychiatrists, and pharmacists like myself, in the hopes that we would provide an integrated consult note that would help the clinician maybe guide that stepwise approach and how they may help their patients in front of them. So in summary, thank you very much, everybody, for joining me and in this whirlwind topic. I want to leave you with these kind of key points where I really do think medication review should happen regularly. Side effect risks increase as one ages, and as well, health and medication goals continue to change. So medications that were technically appropriate for a person as they were younger may not necessarily be appropriate for them now. A thorough medication history and experience is a necessary first step. Involve the patient in the decision-making process wherever you can. Document and communicate your plan as appropriate. And know your resources and collaborate where possible to help your efficiency and to help really support the success. And thank you very much, everybody.
Thanks so much, Pam, for distilling a very complex topic into things that as clinicians we can think about doing differently. Any questions? I knew we could rely on Frank for a question. Thanks, Frank.
Fantastic presentation. Thank you. Not a question, more of a point. I think what we need to figure out as a system is how do we bring this to the masses? Because what you've described is very complex, very labor intensive. So that's good for the 5 to 10% of patients, but how do we bring it to primary care? And I think what we need there is actual good billing. You have to incentivize people. So good deprescribing billing codes. It would save the province money to invest a little bit of money, and then perhaps even deprescribing clinics in primary care, sort of like the Linda Lee MINT clinics, the memory clinics, where we get some primary care physicians in each practice who specialize in this and are supported by specialists. Because what we always do, we design complex systems for the 1 to 3%, but we're not getting to the 97%. So not a question, just a comment about how we should run the business.
And Frank, you bring it up. It's such a complicated regimen, right? And like I had mentioned, there's so many challenges and barriers, and hence the reason why teasing all of this stuff out needs a bigger picture kind of look. And so I bring a small piece to it for sure, but it's definitely a village that needs to really look at this.
Great. Well, thank you, Pam, again, for distilling some very complex information for us into some packaged information that we can use for our clients. I just want to take this time to wish everyone a happy holidays, remind people that we have a few things coming up for educational events. So actually, I'll be speaking at our next one on January 31st on risky business. So an approach to clinical decision-making tool for risk assessment. February 28th, we have current state of understanding and emerging perspectives in pathogenesis and therapeutics for Alzheimer's dementia. Just want to mention too that we have our 2-day core geriatric education series coming up at the end of March, and in May, we've got our 1-day medical geriatric education series, and please save the date, June 15th, for a geriatric refresher day. Our theme is going to be some educational presentations on the theme of dementia. So happy Monday, everyone, and thanks again, Pam.